I'd like to welcome you back to the show. It's our pleasure to welcome back Paul Seegert. He is our resident healthcare expert. He manages healthcare by helping businesses manage their second largest expense after payroll. And what he does is he has an entirely different approach than what the standard fare is, because he understands how the system works, including who is adding on the tremendous costs between healthcare and insurance companies and the like. And his company is PCS Advisors, and I would encourage all employers to contact him to see how much money he could save you while giving your employees a better healthcare plan than they have. Paul, welcome back to the show.
Thank you for having me.
So this is really scary. You've got two stories for us, and the first one is this bill that was signed into law, among other things, was supposed to cap some out-of-pocket costs for some medicines for people on Medicare. And then the question is, well, in order for the drug companies to be able to sell, for instance, insulin at $35 a month, are they going to charge people that are not on Medicare significantly higher prices?
Yeah, to me, we have multiple things going on legislatively addressing healthcare. Some of it we're doing a good job, surprisingly, frankly. Some of it, not too surprisingly, we're probably going to make it worse. And when you look at this Inflation Reduction Act, part of it includes the fact that Medicare here in a few years anyway, you know how they always kind of push these things out, is going to be able to start negotiating pricing for some of their highest cost drugs that Medicare enrollees purchase or get prescribed. It's going to start with 10. A few years later, it could be as high as 20. And however, here's how when you read the bill, here's how it's going to work. If you're Medicare, you can go to a drug company and say, hey, I know you sell this drug currently for $10,000 a month. And you and I have had lots of conversations around all the waste attached to the cost of drugs. There's no dispute on my part that drugs are overpriced. I just don't, what you're going to hear in a second is I don't think that this is a good way to solve it. But what they're saying is the biggest purchaser of drugs in the world, Medicare, can go to drug companies and say, hey, I know you sell this drug for $10,000. We're going to offer you $2,000. If you do not accept that, we're going to give you an excise tax that is equivalent to 95% of your sales on that drug. Now, does that sound like negotiation to you?
Yeah, at the end of a barrel.
Yeah, that is gun to the head negotiation. So naturally, the drug companies essentially have no choice. So that's really price fixing. And here's what really scares me about it. There's a handful of things that I see as that have a high likelihood of producing unintended consequences. But the scary part to me is we already have a healthcare system where in some big cost drivers within the system, employers end up shouldering a heavier load than they should. It doesn't work oftentimes like people think. Employers actually subsidize government payers. So you have and I think we're going to squeeze the balloon here potentially. If a drug company has to sell a $10,000 drug for significantly less to Medicare patients, there's nothing in the bill that stops them from turning around and saying, you know what? For the rest of the payers, the drug is now $20,000. And so I foresee the potential for a significant cost shift to employer plan, which will mean higher premiums, it's a big potential mess there.
So folks, this is not a super accurate analogy, but it's close enough for the Andy Caldwell show and government work. And that is this has happened in higher education. So if a university was charging $10,000 a year for tuition, And the government came along and said, we're going to give every student a $10,000 voucher. That school just jacked up its price to $20,000.
Exactly.
That happened all over education. That whatever the government gave became the new floor, and they just jacked up the price because they said, hey, well, they were able to afford $10,000 before, and if the government's giving them $10,000, then we'll take their $10,000 and the government's $10,000. We're going to just charge them $20,000.
Exactly right.
And so the only twist here is they're going to say in this case that, well, if a senior goes to college, you can't charge them more than the $10,000 we're giving them. Well, then what are they going to do? They're going to charge everybody else $30,000 right, to make up for the $20,000 they lost.
Yeah, exactly. And we already have that precedent in our system where you have within health plans and then within health care, providers, hospitals, in the prescription drug portion of healthcare, it's already uneven. And my fear and my honest expectation, unfortunately, is that we're going to squeeze the balloon even harder and push more cost to employer plans, which already the whole system looks to employer plans to essentially drive all the profit. I mean, it's that severe in our industry. And you mentioned something in the intro about insulin. The bill says two things. One is we're going to cap the out of cost for insulin at $35 on your Part D if you're in Medicare. We're also going to cap, now all these things are pushed out in the future, but eventually they'll take effect. We're also going to cap your total out-of-pocket cost for drugs at $2,000. But when you read through the whole thing, nowhere in there does it actually even mention the total cost of any of these things. So you have permission for the industry to not only continue to potentially overcharge for these drugs, but even increase the cost of these drugs because the consumer is going to be insulated from that. And anytime and it actually ties right into your college tuition example. If the consumer is only going to pay $35, right now the health plan pays $550 for a box of insulin pens. Why not make it $700? So it will, for the first year, it will reduce cost for the consumer, that member. But what's going to happen to their Part D drug plan premiums the next year when those premiums now have to account for drug costs that have gone up and that kind of thing? So it really is disingenuous at best. We're going to drive up cost and premium for a short-term 1 year, perhaps maybe a 1 year win for the consumer.
All right, we're going to be back with more of Paul Seegert at PCS Advisors. Again, folks, especially if you are in the private sector, you're going to need help to control these costs, and your employees are going to need a better plan than the one you got. That's what Paul Seegert does for a living at PCSadvisors.com. We'll be back. Stay tuned. I'd like to welcome you back to the show. Paul Seegert is a professional in managing healthcare for PCS Advisors. I would advise all employers to contact him because the price of healthcare and the quality is going to rise while the quality goes down. And he's somebody that can actually make a difference in that equation. Paul, the Rand Corporation did a ginormous study. 4,000 hospitals in 49 states over 2 years. And they say that, private plans paid more than 224%. For those of you that are bad at math, that's more than double what the Medicare pays. The Hospital Association says, they only looked at a few things and a small portion of overall expenses. The study's not worth the paper it's written on. What's true?
Well, I think my analysis is that the report is very kind, and it includes inpatient and some outpatient things where the variation might be less.
We just lost you there for a minute. You just muted yourself. There you go. Go ahead.
Okay, sorry. There's an interruption.
All right.
When we do analysis on some of this stuff, looking at the data in health plans, it can be 3.5 times, 10 times. I've seen 12 times more that an employer plan is billed for the same procedure as what Medicare would pay in the same facility or a Medicaid patient would pay in the same facility. So we have a system where the government, and by the way, this just blows enormous holes in all of the math that people do to justify the idea of Medicare for all. Could you do Medicare for all? Yes, you could. Not at the same quality that people are used to. I mean, you'd have to sit on wooden benches, I mean, in a metal building, and you would have to really change the product that you're getting, because when someone with Medicare or Medicaid shows up at that hospital, they need 120, 140, depending on the procedure. They could need a lot more than that just to break even on the reimbursement that they get from those programs. And then someone shows up with a jumbo employer plan, and they make maybe a reasonable amount of profit on that transaction. And then someone shows up in a small group plan, a mid-market employer plan, an individual plan, a plan they bought on the exchange, this kind of thing. And then those plans are looked to as the source of profit for the industry. So hospitals are charging those groups, that group of payers, significantly more than those other groups of payers. We don't have a system where we all pay the same thing for the same service. So it's really different than what a lot of consumers think in terms of how it operates. And it just wouldn't work at all if we didn't have employer payers propping up the system.
So, folks, let me reiterate and underscore what Paul just said. The dirty little secret is Medicare pays pennies on the dollar for virtually everything. What does that mean in reality? What that means in reality is, and I had an old friend who just passed away not too long ago, Harris Sherline, who was the president of a little hospital in San Ynez years ago. He said sometimes they would do a procedure for somebody and Medicare would send the hospital a check for like $1.50, literally $1.50 for some procedure, which means they just lost money. The doctor lost money. The hospital lost money. On every single transaction for Medicare, doctors, hospitals lose money. So when they say, well, we need Medicare for all because it's affordable, the dirty secret is the only reason it's affordable is they don't pay the actual price. And they overcharge everybody else to make up the difference. So if they canceled what some of these whack jobs want to do, cancel all private insurance plans and put us all on some form of Medicare, the whole system's going to collapse because they don't have anybody else to charge extra for. And so this is just crazy. It's crazy. It's all based on a lie. It's based on a market distortion. And again, this is why some doctors are no longer taking Medicare patients, because if their practice was inundated with Medicare patients alone, they would go belly up. They would just go belly up.
Yeah, the math just doesn't work. And even with the numbers that in California, for instance, when they've talked about doing a single payer system, they base it on those numbers, and it still on its own is larger than the entire budget by far. So the math it just doesn't work with a basic calculator.
Yeah, and folks, again, California, there's been several bills to institute this. Well, somebody up there did the math because none of them have been passed. It's like usually what they do is shoot first and ask questions later. It's just like with our energy situation right right now. Shut down all oil and gas, shut down Diablo nuclear power plant, shut down San Onofre power plant. We're going all green. Well, somebody finally did the math and said, whoa, now Gavin Newsom saying Diablo nuclear power plant needs to stay open another 10 years. That's an admission that we are nowhere near where we need to be on green, quote unquote, renewable energy as our primary source of power. Well, the same thing with Medicare. See, one of the laws of politics and economics is once you give somebody something for free or nearly free, it's impossible to take it away. And so they promise Medicare as a supplement for health care for the elderly. Well, now it's become, it's a right. It's a vested right of being old and or being infirm at a younger age. Well, but the system's not working. And that system, I can't even remember how many billions and or trillions of dollars this thing is in the hole. And yet they just want to keep growing it and expanding it.
Yeah, it's an incredible situation we have, and what it's causing. You talked about subsidies, how you give them, you can't take them away. We've voted in with this. Well, our Congress, with the Inflation Reduction Act, we are extending the subsidies that have created a situation where if you make $215,000 a year as a 60-year-old couple, you can get subsidy to buy your health insurance on the exchange. And it might be more advantageous to do that than maybe get coverage at your employer or an individual plan that you used to purchase or whatever. So we've drawn people off of other coverage onto government subsidized coverage. And that is going to worsen this problem that we're talking about today, this whole situation where you have one group of payers subsidizing other payers, but that one group of payers that is subsidizing the other payers is shrinking. Employer plan enrollment is going down because we're creating incentive to pull people off of those plans onto government paid plans. So that means the rest of us who are still on government employer paid plans are going to watch our increases annually get bigger because we're still paying the profit.
Right. It's also a double whammy because folks, you're also being taxed to make that happen. So you're actually getting paid twice. You're getting taxed and your personal plan's going through the roof. Hey, Paul, we're out of time. Thank you so much for being with us. We love having you on the show.